Good afternoon, and thank you for joining our Natus e-seminar. My name is Katie Vollrath, and I'm the TCD Clinical Specialist with Natus Medical. Today's topic is application of transducer fixation device with tips and continuous monitoring software. I'm pleased to be hosting today's session in conjunction with our education team. In just a minute, I'm going to introduce you to our speaker and presenter, Donna Lee Davis. But first, I want to go over a few housekeeping items. We've had these questions in the past. Will these webinars be available after the fact? And let me just go over that right now. Our past webinars are available on the Natus Neurology YouTube channel. Note that you cannot receive CMEs for watching these videos. The only time you can get the CMEs are during these actual sessions. So the fact that you can watch them after the fact are for reference only. To subscribe to the Natus channel, and you will receive an email notification every time we add a new webinar. You can find us by searching Natus Neurology on YouTube. Now, if at any time during the session you experience technical issues, you can try to exit the session and rejoin it using the same links and email information you used originally. I'm also joined by my colleague, Bob Nelson, who is listed as the host in your WebEx panel. Please feel free to send him any questions if you have technical issues. During the presentation, I encourage you to write down and submit any questions you may have for Donna Lee using the WebEx chat box either to myself or the WebEx host. And then I will be moderating all the questions at the end of the session. We'll give you a brief pause to send your questions in. At this point, I'd like to introduce our speaker. I've known Donna Lee Davis for many years now and have the greatest respect for her as a clinical nurse specialist and a TCD specialist. She has vast clinical TCD knowledge and experience. Donna Lee began her career in vascular ultrasound in 1986. After working a number of years in Pittsburgh, she was the director of the cerebrovascular laboratory at the Cleveland Clinic for 12 years. I then had the privilege of working with Donna Lee for a number of years after that when she was also a TCD clinical specialist with Nicolay Biomedical. Currently, she is the director of education for her own private company, which is named TCD Education. Donna Lee has earned her stellar reputation as a TCD expert, having presented multiple talks on TCD in these webinars, at conferences, specialty courses. She's well published and has many poster presentations, both domestically and internationally. We are proud to welcome Donna Lee today as she educates us on the many uses of using the fixation device and continuous monitoring. So, Ms. Donna Lee, I'm going to turn this over to you now.
Thank you, Katie, for that warm welcome. I appreciate that. I am going to talk to you today, that's my little grandbaby, one of them, sorry. I'm going to talk to you today about continuous monitoring using the transcranial Doppler technology. With TCD continuous monitoring, you must use a dedicated transcranial Doppler.
Donna Lee, stop for 1 minute. Can you please share your screen? It didn't transfer over like we thought.
Okay, what do I do now, Katie?
Share your screen again, Donna Lee.
Okay, all right, hold on. Sorry, people. Hang on there.
There you go.
Okay, so that's my little grandbaby.
Yep, we see you now.
That's Katie Sue. She'll be 2 next month. Okay, today I'm going to talk about transcranial Doppler continuous monitoring. I think we're good to go now. So to do TCD monitoring, you need specific dedicated transcranial Doppler equipment. So I know some of you probably have the larger imaging systems, maybe you don't, but just know that they do not have fixation devices. The only companies that have the capability of monitoring is the dedicated companies. So the first thing you want to do is evaluate your patient for hyperestosis, meaning do they have a thick head? Keep in mind that African Americans, Asians, elderly women like myself, we all have thick heads. and it's just genetic with races, but as we get older, especially women, we do become thick-headed, unfortunately, ladies. I hate to say that, but it's the truth. Okay, so first of all, identify your window. So what we're mainly going to be monitoring using this is the middle cerebral artery. So you want to positively identify the middle cerebral artery. Okay, so it's best to use the middle window, your medial window. I advise you against using anterior windows and posterior windows, mainly because the eyeball, let me go back one slide here. You see this eyeball thing that's attached to the device. It's big and bulky. And if you're right over the orbital ridge, you don't get a nice connection. If you're using the posterior window, you're right over the ear, and you do not, again, get a really good connection. So successful monitoring requires a nice middle window. So you want to have a really good sonalucent window. Otherwise, you're really setting yourself up for failure. So to do emboli monitoring, the researchers throughout the entire world recommend that you do 1 hour bilateral continuous MCA monitoring. You want to have the sound on because this is an audio-visual phenomenon. It isn't something that you can hand the docs a piece of paper with a picture on it and say, you see that thing right there? That's an embolus. That doesn't work. And for you doctors that are interpreting these, you can't just look at a piece of paper and say, that might be one, I don't know, that might be one. You need to sit physically in front of the machine and play all of these back. So you need to look at it, you need to be able to see it, and you need to be able to hear it in order to accurately identify an embolus. Now, fortunately, a lot of the emboli detection packages are very, very sensitive nowadays. It's not like years ago. The sensitivity and specificity for the SONARA, I believe it's like 94%, which is really good for identifying emboli. So the emboli detection packages, they're pretty sensitive nowadays. Okay, so let's talk about applying the fixation device. Now, truthfully, honestly, it takes longer to put the headgear on and do all this than it does many times to do, say, a bubble study. The agitation just takes a few minutes and you inject, you're done. So a lot of times the whole setup takes a little bit longer to do than even the procedure itself. If you're doing a monitoring, allow yourself at least an hour to an hour and a half as far as time allotment. Then you're not being rushed and you're not aggravating your patient. Okay, so you want to identify the presence of the window, again, in the middle window of the temporal bone. Avoid the ear, the posterior window. I know we all love to use this window back here, but if you think about that eyeball, it goes over the ear, and you don't get a good seal. Mark your skin surface. So just put a little dot there, little purple dot. Again, avoid the orbital ridge here because remember there's a bone right under the eyebrow. Okay, so it affects your probe. Okay, use the middle window again. Avoid using this posterior window here because the ear, you can see how that eyeball would get in the way. And you're not going to have a really good connection. Okay, so we're going to show you how to apply the headgear. Now, this is Sean Malloy, and Katie is going to be applying this headgear. I'm going to be narrating this whole thing just because the sound was real choppy when we played with this earlier, so I'm just going to walk you through as Katie is doing this application for you. Now remember, here's your middle window right here. So this is where we want to be, right in here. I don't see a mark in there, but I can see where the gel has been. Avoid your posterior window. Avoid this orbital window, this anterior window. Okay, so here's our little video. All right, so the first thing is you see the back of the fixation device is like a baseball cap. So it's got this strap that allows you to increase or decrease the size of the headband for you. Place the headband low on the occiput. Also, place it high up on the forehead, not real high, but you don't want to be right above the eyebrow because it'll fall right down on the patient's eye and you lose your integrity. There's also a Velcro strap that you can use to secure the head holder. So you can see here we have this serrated little bar. This is a little T-bar kind of thing that the probe is going to go on. So we're going to go to the next slide, and again, it's another video. Lots and lots of gel. So you can see the serrations here match up with the serrations on the little T-bar here. If you run out of gel, you can use a 10 cc syringe and squirt some in there. But you'll see here we got our knob here, and you've got a little knob here. You see that blue little knob? Knob to knob, okay? There's a left and a right to these, okay? Remember that. If this knob was the other way around, it would be in your ear and in your way, okay? So remember, knob to knob, knob to nose, okay? So you want to be lined up with the nose. This knob wants to be heading towards that knob. You see this joystick here? This is your fine tuner. You tighten your black one first once you get your signal, and that keeps you in the window. So this black knob, and you'll see Katie tightening it up here in a few minutes. That black knob that she's tightening up there, you tighten that one first, it keeps you in the window, and then you tighten this blue knob down, holding your joystick the whole time. You don't want to let go of the joystick because, remember, this is fine motor. So as you're tightening this down, hang on to that joystick. Now, if you are monitoring in the operating room, you're going to want to pop that joystick off. Now, for just regular monitoring, say, you know, you're doing a PFO or you're doing an emboli monitoring, you can leave these on. But in the operating room, they get in the way because, remember, they turn the patient's head and that thing is sticking out. Okay, so again, the number one big rule is to apply gel liberally over the, either you can put it on the skin surface or on the probe surface. If you lose contact and you think your probe is drying out, you don't have real good contact, just take a 10 cc syringe, fill it with some gel, and squirt it in underneath that eyeball. And again, the little eyeball is going to go right over this little screw here, and it slides. This is a little sliding bar that you put the probe on. Occiput, below the occiput is very important. If it's up too high, this thing slides right up, comes right off. Now, the other thing is if you're in the operating room, you know the little blue bonnets we put on people, you want to put the headband on first, then put the blue bonnet over top of the headgear. Don't ever put the headgear over those blue bonnets because you know why? They pop right off. They just fall right off, okay? So put the blue bonnets on afterwards. Pressure points are very important, especially if you're in the operating room monitoring for up to 4 hours, say. Look where the ear is. See this plastic T-bar here, this little plastic serrated bar. Make sure the ear is not touching this area. We have our blue, I guess they're neoprene little pads that we put on to protect the skin. If this ear is too close to this, just pull that little blue pad out and let it pad the ear. Or just use a piece of gauze. But always look for pressure points when you're putting this thing on, okay? Because people if they're sleeping and they're in the operating room, they're under general anesthesia, they're not going to be able to tell you, that thing really is bothering my ear, okay? So always beware of pressure points. It's very important with this continuous monitoring. Velcro strap we talked about. You know, I don't use this all the time, but you can use it. Some people use it, some people don't. It does help secure it a little bit. I put it on before I fine-tune. So I put it on before I literally find my signal. You just want to make sure that that headband is on there snug, okay? And that kind of helps support it a little bit. Okay, so again, headgear positioning is knob to nose. You want to have it above the eyebrows, even maybe a little bit higher here. You can pop these things off. These are the little joysticks. You can pop those off if you need to. You don't have to take them off. Remember, this blue knob goes to knob to knob, knob to knob. If this is over here, your blue knob is on the ear. It's in the way. So remember, there's a right and a left to these probes, fixation devices. There's a right and a left. Some people mark them with a little marker, R and L, or they put a little, you know, a little sticker on them. Okay, so adjust the strap high on the forehead, knob to nose, and you want to be below the occiput. And here's these neoprene pads that you can it just protects the skin surface at all of it. These are all just plastic, but it still is some rough surfaces, so that protects the patient's skin. Okay, so tighten the big black knob first. This one here, tighten that one first. Adjust the Velcro strap and fine tune with the vertical knob here. So this is your fine tuner. Okay, I want to thank Katie and Sean Malloy for helping me with that video. Even though we weren't able to play the audio, I was still able to walk you through how to do this, but I appreciate their help with that. Okay, so another little tip of the day that I have found. So let's orient you here. So here's the little slide bar. This is to find your window. So this will let you go from one window to another. Knob to knob here, and behind this little bar, if you lose your signal, you can take a piece of gauze and slip it underneath this bar. Now what this does is, by pulling by putting the gauze under here, it pushes this portion out towards us and then pushes the probe in towards the patient. So it literally really makes a really good, it's really a really good trick for maintaining your window, okay? So just remember this little gauze trick. It really does work. Okay, the other thing I want to talk to you about is to remember that you always clean your probes with proper cleaning solutions made specifically for transducers. Now, this isn't a monitoring probe here. This is a diagnostic probe, but you can see how the probe looks like it's got a cataract. You never want to use alcohol. Alcohol definitely destroys these membranes of these probes. Avoid alcohol if you can, because long-term use, you're going to get something like this. Okay, so clean these probes with transeptic spray. A lot of these companies have come out with the little towelettes that are safe for probe cleaning. Try to avoid alcohol at all costs. Okay, so now we're going to talk about the monitoring software. So when you go into your software, you're going to do just like you do when you're going in and starting a new patient. Go into the patient little folder there, go into new exam or load exam. So if your patient's already in there, you just select it and say okay. Now your patient should be in there, and I'm going to tell you why. Because you're always going to want to do a complete exam on these people before you do your procedure. So in billing, which we're going to talk about in a little bit, the billing people and reimbursement people, they want to see all of our procedures co-reported with a complete exam. So you want to do a basic TCD. Number one, you get a baseline. What were they like? Walkie-talkie, awake state. Do they have a window, number two? Is it a good window? Can I use it for monitoring? Is it a big enough window that I'm going to have success putting that headgear on? So you should always have your patient in there already when you're going to do these procedures. If you don't, go into new patient here and put all the patient information in. Now, the next part, we go into the very next folder over that's setup. Now, we want to change the display. So let's say we do diagnostics. So the display is showing a diagnostic procedure up there. It's got the vessel labels on one side, and it's got our spectral analysis on the other side. We want to change the display mode. So we want to change it to monitoring. Remember, if you're going to do bilateral, you want to have both probes plugged in, or it won't let you go into bilateral. So in order to do bilateral, put both probes in. Okay, so here's what I'm talking about, the mode. So diagnostic mode is what we're usually in because we're doing bedside subarachnoids or what have you. We want to check off either unilateral or bilateral standard, which standard means we're not looking at emboli. We're just looking at flows. When would you use standard? Well, a lot of times you'll monitor with a tilt table. So we want to see what happens. You know, a patient's having syncopal episodes. So put them on a tilt table, look at the middle cerebral arteries, increase the tilt table, and see if the flows change. We're not looking at emboli. That's what standard means. Standard is just, we're looking at just plain blood flow. HITS, as we all know, stands for high intensity transient signals. HITS are emboli. So you can do bilateral emboli or unilateral emboli. The other thing we do the fixation device for is breath holding. Either, again, unilateral or bilateral. Vasomotor reactivity testing, unilateral or bilateral. So we want to change the look of the screen. A lot of people get confused because they want to go into monitoring. You don't go into monitoring. You go into setup display. The monitoring is just for adding parameters that we use in the OR. Okay, so this is the second icon here. So this is patient, and this is your setup. Okay, so we want to, before we start the exam, we want to choose the M mode and add a vessel label, and I'll show you what I mean here. So right here, this drop-down icon here allows us to choose the M mode. These right here, they say none. So you assign one of these spectra, whether it be right or left. Okay, so you're the one that puts these labels in. Okay? So this is another drop-down. It can either say HITS or it can say history. Now remember what I said earlier. HITS, the emboli detection packages now are very sophisticated, and they're up to 94% sensitive and specific. So they will count emboli for you. They will count artifacts for you. They will pretty accurately differentiate the difference between the two. Okay, so remember, trends can be history or HITS. That's this right here. And it's on the lower left-hand screen. Okay, so right here is where the little drop-down bar that lets you change that. Say we don't want to do hits. We're just looking at flows. Okay, now this is important, and I've done this before. So I've got everything set up. I've got the headband on. I've got both of these. I've got a beautiful spectral waveform here, another beautiful one here, and I think I'm ready to go. You're not ready to go. You're not recording anything. You have to press start record, okay? So you have to, the record button is red, but when it's active and you are recording, it now becomes green, okay? Please remember to do this, because otherwise you're sitting there for an hour and you're not recording anything. You just think you are. Okay, there's also a baseline button to save your starting point. So, and I apologize, the slide is cut off, but here's your baseline button, and here is your recording button right here, and then there's a little green button here. I like the M mode because it's showing I'm in the middle. That's very important. Okay, so here's 40, 50, 60. The only vessel that's out this shallow is the middle cerebral. We know that's the middle cerebral artery, okay, because it's the only vessel that goes out that shallow. 40, 50, 60. We have this at hits. You can see right now it's saying I have 9 emboli on one side, 0 on the other. We have 1 artifact and 30 artifact on the other, on the left middle. So this here is, it's complex. I don't really put a whole lot of faith in this. It's just a drop-down menu that you can change for like energy distribution. I don't use it that much. I don't put a lot of credibility in it. Okay, you can, during the procedure, say the surgeon says to you, Martha, how many emboli did we get when I just put that shunt in? You can hit freeze, and then you can look at what you saved so far. And you can say, well, sir, I think I got, it looks like we got about 8 emboli when we put the shunt in. So here's your freeze button. So this is a better picture. You can see your baseline button here. You can actually, excuse me, save. Let's just say the patient had a Barrett's beat. They've got a bundle branch block. You can save this manually, and it will save it for you what just occurred. But as long as you have this green button on, and I know it says stop recording, but you are recording. Green is go. When you hit this and you stop your recording, then this button turns red, okay? Okay, so I can freeze this right now, and over here, it turns into an event list, and I can click into my event and see how many emboli we got when the surgeon put the shunt in. Okay, so start exam, your record button resumes your exam. So whenever you freeze it, and then it'll say start, and you just hit start exam and you're back at it. So you can literally freeze it during the procedure, which is kind of nice. Okay, so you see how it turned into start? So we start all over again. Okay, and I don't have a picture of these different complexities. I should have put that in there. But like I say, it's like energy distribution and the speed of the cell. Emboli look like little goldfish in these scenarios, because they're traveling. Artifacts don't travel anywhere, so they look very sinusoidal, so to speak. So it's the speed of the cell, the energy, excuse me. Okay, so to print the exam, you go back into patient. We're done now. We're going to go back into patient, and you load the patient to print the data. Now you select from event menu. So you'll see events. I'll show you up here. You can do start, stop, automatic hits, artifact predefined. So you can filter out what you want to save. You can select all, deselect all, check off just, I only want hits, that's all I care about. And then say OK. and it will only print out your emboli for you. Okay, so you choose your event and you save it. You want to repeat the step for each picture to be on the report. So in plain words, I can, once I get the hits on the screen, then I can select it and save, select it and save, so that it will only print out what I have saved, not all these numbers. So you see how I have these saved, 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 saved in their different time frames? This is saving these pictures down here. So you can scroll down and select all the ones I saved, and then hit OK, and it will print them out for you. Okay, so here's ambulance here. But remember, your doctors are going to want to listen to these. It's okay to print out a report and some pictures for them, but you still want to have the physician or interpreting surgeon even look at the audio. They want to be able to. It's an audio-visual phenomenon, these emboli. Okay, so print is on the left-hand side of the screen. You select all, OK, and when you're done, you can go into your default again and set up for your diagnostics. So you want to go back in and set it up for diagnostic for when you're ready to come in the morning. So you can see how here we have this saved, and it gives you a little preview here. Okay, so let's talk about billing. We do have codes now for monitoring. Okay, so they, again, the insurance companies want you to do a complete study and then co-report them with a procedure, okay? So here's your complete study, 93886. Complete evaluation. You cannot do monitoring and co-report with a limited. A limited means the patient's got a thick head, okay? We can't get through the bones, so you can't monitor. So you must use the 93886, the complete study, in order to get paid for these. But you do get paid for two studies. You get paid for your complete study, and you get paid for your procedure that you're doing. Now, vasomotor reactivity. That is, again, if you're giving them Diamox, if you're having them simply just hold their breath, or if you're having them breathe in PCO2. This is your reactivity study. Again, you would do a complete study and then co-report with the 93890. Most of us are going to be using the 93893 or 93892, excuse me, where this is emboli detection without microbubble injection. So this is, let's say we're doing an endarterectomy, or we're going in the cath lab and we're monitoring a cardiac ablation. We're looking for emboli, but we're not injecting anything to specifically look for a hole in the heart. The 93893 is your emboli detection with microbubble injection. So this is specifically for the patent foramen ovale or the PFO. The 93892 is what you would use in the operating room for an endarterectomy, say. The 93890 is if you've got a patient in a doctor's office. I work in a doctor's office. My neurologist wants, the patient has carotid disease. The doctor wants to see how much reactivity the patient has. So we're going to have the patient hold their breath for 30 seconds. And you're going to do the breath holding study. This is the code you would use, your 93890. Okay, again, these must be co-reported with your complete study. You cannot co-report them with just a limited study. Okay, clinical applications. We've talked about this throughout the whole presentation. You know, patients coming in, if they're young, first thing we're going to do, they're having a TIA, the first thing we're going to do is look for the heart, cardioembolic phenomenon, something going on. If they've had a stroke, We're going to look at the carotids and then look at the transcranial to see if, you know, if they're embolizing. There might be intracranial stenosis. We would monitor if they've got, let's say, a vegetative heart valve. Let's say we're just checking for a PFO. The next one down there, we're looking for a hole in the heart. Carotid endarterectomy. I firmly believe that we should be doing continuous TCD monitoring in all of our endarterectomies. It gives the surgeon an immediate response as to what you see, how much flow, residual flow is in the brain following the cross-clamping. So when he shuts off flow to the brain, what's going on up there? And, you know, we all love EEGs and we've used them for so long, but you have to have a certain amount of damage already happening for that EEG to change, where TCD lets you know immediately. So I feel very strongly about endarterectomy, and I would be more than happy to give a little webinar on it someday if you're interested in that. The other thing is the physiologic studies we talked about, the vasomotor reactivity, you know, have the patient hold their breath, CO2, or if you pharmacologically induce vasoconstriction with your Diamox. Okay, I want to thank you again for joining our web. If you are interested in any on-site transcranial Doppler training, whether it be diagnostic or in the operating room, just go to my website at www.tcdedu.com or give me a call. All right, Katie, I'm going to turn it back over to you. Thank you again for your time.
Well, Donna Lee, thank you so much. That was a wonderful presentation, and I think it gave the detail that people have been requesting about this subject. So at this point, we'd like to open this up to any of your questions. I'd like you to send your questions to me. You can also copy our host, Bob Nelson. That way we'll make sure one of us sees the question. So I'm just going to pause for a moment or two. Oh, wait, we've already got one question. So, Donna Lee, are you ready?
Yep.
This is the question, can I monitor the basilar artery continuously?
You know, that's a really good question. Have I monitored the basilar? Yes, but you can't use the headgear. So what you have to do is find the basilar and literally hold it for a half an hour or an hour, depending on how long the doctor wants you to hold it. It is, it's painful as far as ergonomically on your wrist. The best is to have the patient lay on their side, prop your hand up and just hold it manually, but you cannot use the headgear. And Katie, does another company have, I don't know if they even have I don't know if another company even has the ability to monitor the
Not that I know of, Donna Lee. You know, I guess it is an important thing, though, to be aware that you can monitor if the patient is having posterior symptoms. We could do the basilar, but like you're saying,
you just have to hold it. I mean, yeah, you have to hold the probe. And it's, you know, half an hour doesn't sound like a long time, but 30 seconds doesn't sound like a long time when you're holding your breath. It really is. I mean, it's hard on the wrist. It really is, I have to admit.
All righty. Well, thank you. Okay, what do you use? I think you covered this, but what do you use specifically to mark your dot where you find the window?
You know, in the operating room and even in the neurointensive care units, they have little surgical markers. They look like pencils. They mark the skin surface in the OR, you know, put the X on the correct leg that they're going to chop off, for example. We use it in the NICU and the critical care units for marking our pedal pulses and our popliteal pulses when we're evaluating patients' peripheral vascular status. So everybody has them. They're just long pencil-like felt marker pencils they're just called surgical skin markers. And all
right,
of
I think we used to call them vein marking pens.
Yeah, vein marking, exactly, yep.
All righty. Here's an interesting
really well.
Thank you, I'm sorry. Here's an interesting question. You know, we get this a lot. Any advice on using the headgear on a child?
Oh boy, that's a tough one. So babies, we can't. Neonates, we can't. The kid has to be at least toddler age. You make your headgear as small as you can, using that baseball cap, you know, device in the back. And I either pad it with lamb's wool, or they have things called ABD pads that are like abdominal pads that we use. They're very thick dressings. You line them inside. So, you know, where you put the blue neoprene pad, you put your lamb's wool or your ABD padding right over top of that, and it brings the size down even smaller. So by padding the front and the back, either with lamb's wool or a ABD pad, it works very well with the toddler, say, if you wanted to monitor a child. Because you can't monitor these babies, you just can't put that headband around the head. The skull is just too soft.
Mm-hmm.
Yeah.
Well, thank you. Let's see. How tight does the headband have to be?
Well, it's got to be so that you can't move it. When I put it on, I always grab the big knob and kind of jerk it. I don't, just to make sure that it's snug on there. You know, your patients that are awake, they can say, oh, that's too tight. And you have to explain to them it's got to be snug. So I uncrank it like one crank and say, is that better? The Velcro strap definitely helps. But remember, your patients that are asleep, they can't tell you. You know, you don't want, it's going to leave a little red mark that everybody, I mean, it goes away. It's nothing big. But you want to have it so that it's snug, so that you cannot move it. And, you know, you don't want their eyeballs bugging out. And a lot of people, I've had people that have migraines, and they said, well, that really feels good. You know, you get people on the other side of the spectrum that say, wow, that feels really snug, but it feels good on my head.
All right, thank you. More on the headband itself. How do you clean the blue pads on the headgear, or can they be cleaned at all? Are they a one-use thing, or can you clean them?
Well, you know, I know companies say no, just throw them out. But if you don't, if they're not bloody, I usually take a betadine scrub like we have in the OR to clean our hands with, and scrub them down and rinse them out real good and let them dry. Now, if they get bloody, I do pitch them. And and especially endarterectomies, because the posterior portion of the headgear is so close to the OR site itself, many times the posterior pad will get real bloody. It'll get messed up. So just pitch them.
Yep. All right, you mentioned carotid endarterectomy, Donnelly. We got one question here. It says, what do I do about electrical interference? So, for instance, like if they're doing a cautery, any tips on that?
You know, Katie, there's nothing we can do about that. I mean, with the Bovie, it's going to obliterate your screen.
Yeah.
There's nothing you can do. Now, sometimes, if I'm in a cath lab situation, I will get an extension cord and plug in outside of the room that has the fluoroscopy and what have you, to clean up some electrical interference, like you just get the noise, ambient noise kind of thing. If you plug in outside of the unit where you are, sometimes that will make it go away. Don't use the outlets in the cath lab room itself.
It's a good suggestion.
That's a good trick, and it does work. But as far as Bovie, no, you can't. There's nothing you can do about it, except be sure to take your earbuds out because it'll blast your eardrums.
Right. Okay, we have one last question. If there's any others, please send them in now. Can the monitoring probes be used for diagnostic applications?
You know, it can, Katie. They're the same frequency. Of course, they're 2 meg. The only thing is that, you know, we've got our gloves on, we've got gel. A lot of times the little joystick will pop off very easily because of the gel if it gets in there underneath it. I always just tape it, just put a little piece of tape around it, and that way I don't lose that joystick, because you definitely need it. You have to, your fingers will get too cramped up if you just try to use that little probe itself without the joystick. It's just too small. So just put a piece of tape around it, and it'll work for you. But yeah, you can use them. I mean, we've had probes break down, and you know, they just break, they die, and we've used monitoring probes for a couple weeks until I could get a replacement.
That's exactly what I was going to comment, that for those of you that have a diagnostic transducer plus the monitoring transducers, if, just as Donna Lee said, if something happens to your diagnostic transducer, or if you feel like you're hearing some sort of interference, the monitoring probes are identical in function to the diagnostic probes. So you can always use them, as Donna Lee just said, until you can order another diagnostic.
Yeah, I'm telling you, just try not to use alcohol to clean these probes. And, you know, I travel all over the country, Katie, and I see this all the time, and it's like, people, please, you're really, really decreasing the life of your equipment by using alcohol. I know it sounds good, but they have so many different types of probe cleaners for these transducers that we can avoid damaging the surface of these crystals.
Good advice. Well, that concludes all of the questions. So again, I want to thank all of you for attending our TCD webinar today. Remember that, as we said earlier, you can view this again. Give us a couple of weeks to get this posted, but all of our webinars are available on YouTube. And again, you can find those by searching Natus Neurology on YouTube. And again, those would not come with CMEs, but a lot of times when we have these webinars, people either have to leave early or they just want to review the material. So once again, thank you. We are planning another webinar, TCD webinar for December 15th, same time, 3 o'clock Central, 4 o'clock Eastern, and 1 o'clock Pacific. And the title will be related to sickle cell evaluation with transcranial Doppler, and we'll be reviewing waveforms and findings and etiology, et cetera. So we hope that you'll all join us for that, and once again, thank you so much for tuning in today. Donna Lee, thank you also.
Thanks, Katie. Okay, bye-bye all.
Bye.